Community participation and community ownership is one of the key pillars of the primary health care strategy. So with support from the European Union and in partnership with the Ministry of Health and the rural district councils, we have been able to have, a critical mass of community volunteers. And these are community volunteers that are knowledgeable, community volunteers that are well informed about health issues. As a result, they are able to hold authorities accountable. They are able to demand for their health rights as enshrined in the new constitution. They are able to collect community views, make sure that community voices are heard, both in health planning and in implementation. So with community feedback mechanisms, we have been able to have a vehicle for information flow, both from the health facility to the community, and also from the communities, to the institutions. And we see this program as a catalyst in terms of bringing, community ownership in health processes, in terms of enhancing health literacy and health-seeking behavior. We have had situations before where some people would get sick at home because they don't have much information in terms of what are the charges at the health facility. Right now, the government came up with a user fee policy which exempts, pregnant mothers, under fives, those aged 65 years and above from paying any fees at the first point of entry. But when people do not have that information, they will assume that when I go to the health facility, I may be charged something. And when they do not have money, they may end up getting sick at home, only to then go to the health facility when their situation is quite maybe worse. So with this program, what we have seen is, because if you look at health center committees, they derive their mandate from the community. So because they get their mandate from the community, they are obliged to give feedback to the community in terms of developments at the health facility, in terms of also requirements at the health facility, where communities may need to provide any support, be they with sometimes even just providing labor, if they want to come up with a nutrition garden. Right now, almost all the health facilities where we are working have waiting mothers' homes. Through the waiting mothers' homes, we have seen a marked reduction in home deliveries. So health literacy facilitators, the community health monitors, the village health workers, the health center committees that we work with through this community feedback mechanism have really improved, information flow. They've also really improved, relationships between communities and health workers. Previously, health workers were seen as demigods by communities. Communities could not even question decisions, made by health workers, because we felt health was for, the trained nurses, health was for the doctors, health was for the lab technicians, the environmental health technicians, and so forth. But because we use the public health, lens in our work as community working group on health, we have said health is a people's issue. It is important that everyone in the community has a role to play in terms of supporting the health system, also in terms of even contributing resources, to our health delivery system. As you are aware that from our own national budget, we have never had enough resources to support with our drugs, to support with equipment, to generally support the functionality of the health institutions. So communities, they then play a very important role in terms of looking at these institutions as their facilities, because at the end of the day, these institutions, they serve those communities. Yes, there are still gaps. If you look at the issue of emergency services, the issue of ambulances, there's still a very big gap. Most of the districts are operating with the 1 or 2 ambulances, and in most cases, maybe the ambulance may be there, but you'd find sometimes it doesn't even have fuel, or sometimes it is broken down. As a result, we have seen the burden has now been shifted to the community to come up with their own transport plan, to come up with alternative transport. And in most cases, the alternative transport is not suitable. And as a result, it has also increased the out-of-pocket costs to the community. Because when they are to come up with that alternative transport, they then end up sometimes being taken advantage of in terms of the charges that those private transporters are using. But also the bottom line is those kind of transport are not suitable, especially like to carry a pregnant woman. And it ceases also to be an emergency if we use a mode of transport that is not properly equipped with emergency equipment. So it's one area. And then we have also seen a gap in terms of human resources for health. There's still a shortage out there for health workers, especially nurses in rural health facilities. In some cases, you'd find a rural health center has got 2 qualified nurses, a primary care nurse, and these are the same nurses who also attend meetings, either meetings by NGOs, meetings by Ministry of Health, and so forth. And when sometimes they go to attend meetings, the health facility is left without any qualified nurse. So what we have been saying to the government is, let us also review our staff establishment. Right now we are using the staff establishment of 1983. In 1983, the Zimbabwe population was about 7.5 million. It has since doubled. Disease burden has increased, but we have still maintained the same number of health workers. And what we have been saying, let us also remove the freeze on employment of health workers. Because right now we have got almost about 4,000 qualified nurses sitting at home when most of our institutions do not have adequate health workers. And then the issue of drugs. This has been a perennial issue, a perennial challenge. Most of our health facilities are really struggling in terms of stockouts. And in some cases, you can even not find sometimes even simple, drugs like Panadols. And as a result, patients are given prescriptions. And when you are in a rural community, you are given a prescription. What it means is you have to board a bus to the nearest town where you can find a pharmacy. And that also brings the challenge of the out-of-pocket costs, because you need money for bus fare. You may then also need money for lunch when you go to that nearest town. You may need accommodation and so forth. So all those things are the barriers that I think we need to address. And then we still have some health facilities that are operating without water. And that's another big challenge, especially where deliveries are happening. And as a result, you find some clinics are then asking pregnant women to bring their own water. So that's another challenge. And of course, generally, there's been a challenge of the food security. In some cases, pregnant mothers, when they go to the waiting mother's home, they have to cater for 2 kitchens now, where the home they are coming from and at the waiting mother's home. And with the current economic challenges, sometimes it then brings some serious financial constraints to the pregnant woman. Yes, as community working group on health, we have been on the ground, and we have been training on health literacy. We have health literacy facilitators, and these are facilitators who come from those communities who speak the local language. And it is always good, for communities to have facilitators who can converse in their own language. So we have a mass movement of health literacy facilitators that we have trained. We have also been training and capacitating health center committees, because they play a very important governance role in our health delivery system. And right now, as I speak, almost every health facility now has a functional health center committee. And as CWGH, we have developed the guidelines together with the Ministry of Health on the roles and responsibilities of these health center committees. We have also gone a step further by developing the training manual. And this is the standard training manual that every partner who now comes in to work with the health center committees, they have to use that training manual. We also have the community monitors. They play a very important role because they are the ones who collect views from the community on what needs to be done or what are the gaps in the health delivery system. And these community monitors have been trained in basic health research, so they are able to collect community views, analyze, and come up with the reports that they can use to engage with their local authorities, with their elected leadership, with their traditional leadership in their communities, so that jointly they can come up with local solutions on how to address some of these concerns.